Hi, this is Andrea Kane, and I'm here with you for HIT 292 reimbursement methodologies. We are now on week 2, and we actually have 3 chapters we're going to cover this week. This is chapter 2, so it's the first of 3. Let's take a look. Our learning objectives include discussing the major types of health insurance plans, differentiating individual health plans from employer-based healthcare plans, explaining the provisions of a health insurance policy, describing characteristics of managed care in terms of quality and cost effectiveness, describing the common care management tools used in managed care, explain the cost controls used in managed care, and describe the types of managed care organizations. So let's start out by talking about health insurance. Health insurance may be individual, purchased by an individual or family from an insurance agency, or it may be employer-based, where an individual or family obtains as part of an employment benefit package their health insurance. So you have types of health insurance. You have single coverage, which only covers the insured. You have family coverage that covers the insured, and it can include spouse, children, young adult, or disabled person. Any or all of those. A risk pool is a group of individual entities whose healthcare costs are combined for evaluating financial history and estimating future costs. So a risk pool may contain individuals, employers, and associations. Risk is the probability of incurring loss. So the bigger the risk pool, the less the probability is of the insurance company incurring loss. That's why they like to have such big risk pools. And the risk pools typically include everyone from young and healthy all the way through to those who have complex chronic conditions. So health plan terminology, you need to know what benefits are, premiums are, policyholder, and cost sharing provisions. And let's see here. If you wanted to open your textbook and follow along with me, we're starting on page 15 for chapter 2. And they go into all of these concepts. So make sure that you have read these. But this is going to go into that. The other thing I'd like to point out to you is that in the back of your book you have a glossary, and all of the terms that are in purple in your textbook are explained in the Appendix A, which is a glossary starting on page 243. So if you're reading through and you find a term and you're not quite sure what it is, and even though they define it in your paragraph that you're reading in the textbook, it may still be a bit challenging, flip to the back to the glossary and take a look there, because sometimes they will have the definition, but it'll be slightly different and it may make more sense. So I want to put that plug in there. But anyway, benefits are covered services. Premiums are payments that the policyholder has to make in return for the healthcare coverage. A policyholder is different than the beneficiary. The policyholder may be a beneficiary, but typically the policyholder is the one who purchased it or is given it through their employment, and beneficiaries are others. But again, a policyholder can be a beneficiary, but typically beneficiaries are often outside of that. Cost sharing provisions are things like out-of-pocket expenses or a deductible, where someone has to pay an annual amount of money before the insurance will assume its share of the liability. So, provisions of health insurance plans. The policy, your insurance policy, is a formal contract between the insurance company and an individual or group for whom the company is assuming risk. So they have a certificate of insurance, they stipulate what is covered, and they have a summary of benefits and coverage. It's supposed to be in plain language. Not always is it, but it's supposed to be. Sections of a health insurance policy include definitions, eligibility and enrollment, and benefits. And you can see here the examples of what are included in those. Sections of health insurance policy, they have to tell you the limitations, how they limit the extent of the benefit. For instance, they have to go over the cost-sharing provisions, such as co-insurance, co-payment, tiered benefits. Those are things that they have to cover in the limitations. And so you can look here in your book, it says look at figure 2.3 in textbook. And that is on page, where have they put it? I'm seeing everything but that. Oh, figure 2.3. Look at the bottom of page 31. Bottom of page 31. And that doesn't make any sense. I think they meant figure 2.2. I would suggest you look at figure 2.1 and figure 2.2. I think this isn't a typing error by the textbook company. Sorry about that. But that's where you could get some examples and some information. All right, moving on. Now they mentioned figure 2.2 about how you calculate cost sharing or co-insurance. And it shows you at the bottom how an example for that, bottom of page 23. They also have to tell you exclusions, anything that's non-covered. And typically those are going to be experimental or investigational procedures or services, things that they deem medically unnecessary, cosmetic procedures, and non-FDA approved medications. They will tell you what you will have to do if you're going to have a procedure in terms of prior authorization, pre-certification, prior approval. They'll talk about coordination of benefits if there are multiple payers involved. And they'll talk about other party liability. For instance, if something happens in terms of an automobile accident or workers' compensation, who pays first and that type of thing. So moving on to managed care. Managed care came into being because there was a push to control costs. Their goal is to provide affordable, high-quality health care, but to manage access, cost, and quality to make that happen. The information about managed care starts at the top of page 25. Characteristics of managed care. High-quality care has not always been at the head of that. But that is something that has fairly, within the last 5 to 10 years, really moved to the top. But they look at selection of providers, health of populations, care management, and then quality. They also look at service management, reimbursement, and financial incentives because, again, managed care is all about controlling the cost. So they're looking for cost-effective care. And some of the tools that they use to make sure that this happens involve care management or case management. The primary care physician in a managed care organization is your gatekeeper, and they control referrals to specialists, whether you get them or don't. Disease management, they work to prevent chronic exacerbations, or chronic disease exacerbations, I should say, things like congestive heart failure, coronary artery disease, asthma. And try to improve the health and quality of life by reducing hospital admissions, making sure that patients are cared for maybe in the physician office rather than needing to go to urgent care or the ED. They also have been pushing evidence-based clinical guidelines to guide clinical decision-making to make it be based on the best healthcare possible and to standardize it for optimal care to all patients across all providers. Some service management tools that are used include medical necessity and utilization management. Medical necessity looks at whether or not it's truly necessary, warranted by the patient's condition. That's really the bottom line. Does the patient's condition require the test, treatment, diagnosis, cure, service, those types of things? Utilization management looks at the healthcare facility's efficiency in providing the necessary care to patients in the most effective manner. For instance, should the patient receive outpatient surgery versus inpatient surgery? They're looking to prevent overutilization or unnecessary consumption of healthcare services, especially those that are expensive. So those are two types of service management tools that are utilized not just by managed care organizations, although they certainly innovated those, but they're now used by every third-party payer, including the government. When you're talking about utilization review, they perform clinical reviews, usually by an RN, although RHIAs and very skilled RHITs have been able to do that as well, but typically they want a nurse, an RN, doing the clinical reviews. They review against established criteria, and there's a couple of different types of criteria that they use. You may have heard of InterQual, that's one type. Then there's peer clinical review using physicians to provide clinical opinions, and then there's appeals consideration, where you have a qualified expert clinician in the same specialty who wasn't involved in the initial decision, looking over the utilization. So this goes on to service management tools. Sorry, losing my voice a bit. Sorry about that. So we talked about the physician or the primary care physician being a gatekeeper to determine whether referrals are warranted. We talked about prior authorization, making sure that pre-certification occurs, that medical necessity is validated. And then second, third opinions are often required before an expensive surgery, because again, they want to prevent unnecessary tests, treatments, medical devices, or surgical procedures, and they try to obtain those from experts within the healthcare plan. Then they also have case management, prescription management, and prospective reimbursement. Case management really coordinates complex and high-cost cases or patients who have many needs. Prescription management is typically done through a formulary where they limit the drugs that are available to be covered under the plan, and they have pharmacy benefit managers who look at patients who are on multiple medications and identify opportunities to either reduce the medications, use generic medications, those types of things. And then prospective reimbursement, plans share the risks of the costs of the beneficiary's care with providers. So the providers are incentivized to be very careful in what they're doing, and not be wasteful. And oftentimes that means one predetermined amount is given for all the care that's received. So the more times the provider sees the patient, the less chance they have of making a profit. So it really incentivizes them to utilize their skills and abilities with the patient to keep them healthy at home, and does not increase payment for the complexity or extent of services. So we're still on managed care. We're talking financial incentives to the providers and to the members. And again, it's all about the cost, trying to keep costs down so that they can get bonuses, so that cost sharing is less, so that that members, both providers and members, have, quote, skin in the game, meaning that they could both lose money if they are not careful about how they utilize services. So types of managed care organizations include HMOs and PPOs. HMOs have a variation of freedom. They have closed and open panels. There are basically four models of HMOs: staff, group practice, network, and independent practice. PPOs tend to be virtual and decentralized. They influence members to use in-network by higher cost-sharing provisions for out-of-network, and they use discounted fee schedules instead of capitation. Capitation is where they give one lump sum, and the providers have to care for all the patients, all their visits, based on those lump sums. So going back to types of managed care organizations, there's another one called point of service. This is where members choose how to receive services at the time that they need them. They're like open-ended HMOs. So this goes back to our patient connection. Remember, we have two patients. We have Olivia and we have our other gentleman who's not actually here this time. it looks like, and they want to take you through and give you examples. And so because Olivia has commercial insurance rather than our other gentleman who I think had Medicare, they're going to take us through and show us her cost sharing limitations. So this would be good to scroll through just to familiarize yourself with that. But all of the information for Patient Connection is on pages 32 and 33 in your textbook, and it might be easier to see and review from there. And that is it for Chapter 2. I'll be back shortly to talk to you about Chapter 3. Thanks.